SwayamPrabha. Digital India. Educated India.
Today we will discuss the pathological aspects of diabetes mellitus related to pathogenesis and complications of diabetes mellitus. The pancreatic neuroendocrine part, which is present throughout the pancreas, comprises islet cells, and the islet cells are two types. One are the major hormone producing islet cells and other are the minor hormone producing. The majors are insulin, glucagon, somatostatin and pancreatic polypeptides. There are some minor hormones which are also produced in the pancreas by the D1 cells, which produces vasoactive intestinal peptide, and enterochromaffin cells which produce serotonin. There are various ways to demonstrate pancreatic islet cells by immunohistochemistry, and the other is by electron microscopy. Majority of the pancreatic islet cells are the insulin producing, which are beta, and the others are alpha cells which produce glucagon, delta cells which produce somatostatin, and the PP cells which produce polypeptides. These hormone producing cells can also be differentiated based on the character of these neurosecretory granules. The different hormones produced by these or stored in these neurosecretory granules, they have different shapes, and based on the shape and size of these granules, one can differentiate between these hormone producing cells. For example, this is the insulin producing cells, and these neurosecretory granules, they have a halo around these electron dense material, and they are crystalline, rectangular in shape, whereas the other hormones, they are rounded, and the glucagon producing cells, these neurosecretory granules, they have the central electron dense part, the peripheral part is less electron dense. So based on these characters, one can differentiate between the different hormones producing cells. So diabetes mellitus, as we know that diabetes is characterized by the hyperglycemia. Basically it is the abnormality of the glucose. As we know that glucose is produced by these insulin, is regulated by these insulin secreting cells, that is the insulin hormones. The other glucose metabolism is also affected by the other hormones, for example the glucagon. So either there is a reduced insulin secretion that affect the glucose metabolism, or there is decreased glucose utilization. For example, in the organs where the glucose is utilized, there may be defect in those organs, therefore it causes the raised glucose levels in the blood. And based on these features, either there is defect in the insulin production, which is the pancreas, or there is defect in the glucose utilization, and these are the three major organs which utilizes glucose and store glucose. One of them is the liver, the other is the skeletal muscles, and the peripheral fat. There can also be defect in the target organs where the insulin which is produced in the islet cells released in the blood and goes and act on these receptors on the target cells. So if there is any defect in the target cells receptors, the insulin will not act and the glucose levels may be raised. So any of these three mechanisms may be involved in the hyperglycemia. Now what is diabetes mellitus? According to the American Societies of Diabetes and the WHO, they are defining criteria for the diagnosis of diabetes mellitus. So any fasting glucose level of more than 126 milligram percent, or any random blood glucose level more than 20 milligram percent, or the after the loading dose of glucose, that is 75 gram, at the end of the 2 hours the glucose level is more than 200 milligram, then the person is diagnosed as diabetic. But to be remember that only the one single reading is not enough for the diagnosis of diabetes. All these tests has to be repeated at other time for the definitive diagnosis of diabetes mellitus. There are criteria which define what is the pre-diabetic or the people who are more prone to diabetes. What is the pre-diabetic state? What we call as the impaired glucose tolerance test. There are some criteria, that is the fasting blood glucose between 100 and 125 milligram, or the 2-hour plasma glucose between the 140 and 199 milligram percent, or the glycated hemoglobin levels which are less than the defining criteria of diabetes mellitus. Now, what is the significance of diagnosing the pre-diabetes or the impaired glucose tolerance? It has been found in large studies that 1/4 of these patients who are pre-diabetic, they develop diabetes mellitus over the time, and mostly within 5 years. The second is, all those patients who are pre-diabetic, the chances of cardiovascular complications are more as compared to general public. So that is the importance of diagnosing the pre-diabetic, and these patient has to be kept under strict diabetic control. Basically, diabetes mellitus, there are many causes of diabetes mellitus. Mainly there are what we call the type 1 and the type 2 diabetes. Earlier we used to call as the juvenile diabetes mellitus type 1, and the adult onset diabetes mellitus, which is type 2. But now juvenile and adult onset, the terms has been discarded. They are obsolete terms, and we use the type 1 and type 2 diabetes. There are basic differences. Diabetes mellitus is classified into two groups, type 1 and type 2. Earlier we used to call type 1 diabetes as the juvenile onset diabetes mellitus, and the type 2 diabetes as the adult onset diabetes mellitus. Now, the juvenile and adult onset terminology has been deleted. They are obsolete. They are just called the type 1 diabetes mellitus and type 2 diabetes mellitus. The majority of the patients are of type 2 diabetes mellitus, which comprises about 90 to 90%, 5% of all cases, and the minority, about 5 to 10%, are type 1 diabetes mellitus. So, the majority of the patients are type 2 diabetes mellitus. There are basically some differences between the type 1 and the type 2 diabetes mellitus. For example, type 1 diabetes mellitus, the clinical onset is in the childhood or adolescence. The children, they are of normal weight, or they may present with the weight loss. As compared to the type 2 diabetes mellitus, where majority of the patients are obese. In type 1 diabetes mellitus, there is decrease in insulin secretion, and there is absolute deficiency of insulin hormones. Whereas in the type 2 diabetes, the insulin may be normal or may be increased in the initial stages, and it is decreased in the later stages. The type 1 diabetes mellitus is autoimmune, and one can estimate the autoantibodies in the blood. These patients are more prone to diabetic ketoacidosis in the absence of insulin therapy. The majority of the type 1 diabetes patient, they may show some linkage to the MSC class 2 genes, and in the pathogenesis, actually there is a dysfunction of T cells, which causes the destruction of the islet cells and decrease in the islet cell populations. So, what are the differences in the pathology of type 1 and type 2 diabetes mellitus? Mostly seen in the animal models and in the experimental studies, and sometime in the autopsies. It has been found that in type 1 diabetes mellitus, there is inflammation in the islet cells. These are the lymphocytes which are infiltrating in between the islet cells. So, this is known as the insulinitis, and there is a decrease in the number, atrophy of these islet cells, and decrease in the number, and the end stage, there is a loss of these islet cells. Whereas in the type 2 diabetes mellitus, the number may be increased initially, but it is later on it is decreased. But is more characteristic is the deposition of the amyloid material. This is the amyloid materials which is deposited in the islets and causes atrophy of these cells. Now, what is the etiology or the causal relationship is not well known, but probably the these amyloid deposition causes atrophy of these islet cells. Now, the type 1 diabetes, it is a multifactorial. There are some genetic factors, there are some environmental factors. So, it has a complex genetic association, and it has been found that there may be some loci which is related to the class 2 MSC molecules on the chromosome 6p21 regions, and these patients who are HLA positive for HLA DR3, DR4 or both, they are more prone to type 1 diabetes. There may be some gene encoding for the T cell inhibitory receptors which are involved in the type 1 diabetes. It has been found that many patients of type 1 diabetes, the onset is after the viral infections. The patient present with some fever and immediately there is a onset of diabetes. So, there is maybe correlation between the viral infections, maybe some common antigen between the virus which are affecting the islet cells. That may be the molecular mimicry involved in the pathogenesis of type 1 diabetes. Now, there are some direct evidences and there are some indirect evidences in the pathogenesis of type 1 diabetes regarding the autoimmunity. The presence of inflammation, T cells, the antibodies against some of the islet cells component, or maybe the antibodies, circulating antibodies against the insulin, glutamic acid, decarboxylase, which is involved in the synthesis of insulin. All these factors contribute to the autoimmunity. There is a reduction in the B cells in the end, and it was found that there may be involvement of the CD4 positive helper T cells and the CD8 positive cytotoxic T cells, or maybe some cytokines which are secreted by the inflammatory cells which infiltrate the islet cell and causes the destruction of these islet cells. This cartoon shows the phenomena of autoimmunity as in all other diseases. It may be that some of the antigens which are released from the islet cell, they go to the regional lymph node, and with the help of CD4 positive cells, helper cells, and the MSC class 1, they cause the activation of these cells, and these cells produce some cytokines which may directly affect the islet cells or may affect the cytotoxic T cells, may involve the macrophages, and all these contribute ultimately in the destruction of islet cells. Now, by these patients who are predisposed to diabetes mellitus type 1, genetic factors are already there since birth, but why they present after sometimes in the late childhood or in adolescent. Initially, there may be some genetic predisposition, there may be some other factors which are involved, for example, the viral infections, and all these, it takes time for the destruction of the islet cells. And when there is absolute deficiency of insulin, at that time the patient present with diabetes mellitus. As compared to the type 1 diabetes, type 2 diabetes mellitus, the genetic factor may be involved, there are some environmental influences, or there may be some metabolic defects. Of all the environmental factors, the most important is the obesity and the lifestyle. The people who are more obese, who have sedentary lifestyles, who have dietary habits, who takes more junk foods, they are more prone to type 2 diabetes. As compared to type 1 diabetes, there is a strong genetic disposition for type 2 diabetes. It has been found that more than 90% of the monozygotic twins, they develop diabetes mellitus. In the first degree relatives, the chances of type 2 diabetes are about more than 5 to 10 times as compared to the general population. There may be some metabolic defects. As the person become obese, people develop insulin resistance, and it ultimately leads to beta cell dysfunctions. So all those factors which are involved in the glucose metabolism may be involved in the type 2 diabetes. For example, in the liver, the glucose which is stored as glycogen broken down, and it causes the gluconeogenesis, which is the factor for the raised fasting blood sugar. In the skeletal muscle, the underutilization or the decreased utilization of the glucose leads to the postprandial glucose level increase. In the fat, there may be lipolysis in the absence of insulin. Actually, insulin is the best anabolic hormones. So whenever there is deficiency of insulin, the catabolism starts, and that ultimately leads to the raised glucose levels in the blood. Now there may be some other factors which are involved. It has been found that the people who are obese, they develop a resistance to the insulin, and this resistance to insulin is the most important factor in the pathogenesis of type 2 diabetes. Maybe that there is some blockage of the action of the insulin on the target organs that leads to the down regulation of this downstream pathway, and ultimately decreased utilization of glucose. It has been found that the obese people, the environment is more of pro-inflammatory. Many cytokines are released by these adipocytes, which causes the inflammation and ultimately leads to the insulin resistance. The another mechanism which may be possible, that may be some genetic abnormality, the insulin resistance, may be some receptors on the cells which are mutated, and the insulin action does not take place on these receptors, and this ultimately leads to the underutilization of glucose. So all these factors actually leads to the NF-kappa pathway activation, which is the most important pathway in the inflammations, and ultimately leads to insulin resistance. There may be some other factors, for example, the release of free fatty acids from these adipocytes, which causes insulin resistance, or maybe some adiponectins, leptin levels, which are all involved in the metabolism of fat, which leads to insulin resistance. And this insulin resistance, initially the beta cells, the islet cell, they try to compensate this insulin levels. So there is hyperplasia, but ultimately it leads to the dysfunction of these cells, and the number of these cells also decrease, as I told, because of the deposition of the amyloid, which may cause the pressure atrophy. So this chart shows the pathogenesis of type 2 diabetes, which may be an environmental factor, which may be the obesity, or maybe some genetic factors, which ultimately leads to the insulin resistance and the dysfunction of the beta islet cells, leading to the hyperglycemia and type 1 and type 2 diabetes. Now initially, as I told, that this insulin resistance leads to hyperplasia of these islet cells and increased level of insulin. But in the end stage, because of the resistance, there is a dysfunction of the beta cells and decreased number of beta cells, which causes increased glucose levels. Now this cartoon shows the complication of diabetes. Diabetes affect from head to toe, all organs are affected. There is no organ which is not affected by the diabetes, and this is the slow damage. Therefore, many times it is not realized in the initial stages. When the full blown complications occur, the patient may realize that the diabetes has affected all the organs. Now, vascular complications of diabetes may be the macrovascular, may be the microvascular. The microvascular mainly involve the small vessels, which causes the nephropathy, retinopathy and neuropathy, where the macrovascular, they involve the major vessels, medium sized vessels, and all organs are affected. For example, it causes the atherosclerosis. All these patients, they are more prone to, or they have accelerated atherosclerosis, which causes the myocardial infarctions, cerebrovascular accidents, the peripheral vascular diseases, etc. Now, it has been found that the chances of atherosclerosis in the diabetic patients are more as compared to general population. One is the raised glucose levels, the other is most of the patient, for example, the type 2 diabetes patient, they are associated with the dyslipidemia. So, along with the dyslipidemia, these chances of atherosclerosis are more, which is further complicated by the hypertension. Diabetic patients are more prone to hypertension also. So, all these factors leads to damage of the endothelial cells, which causes the atherosclerosis. The other is the hyaline arteriosclerosis and the diabetic microangiopathies. Now, as I mentioned that diabetic patients, because of the atherosclerosis of the major vessels, in these patients they develop atherosclerosis and thrombosis and the embolism of the medium sized vessels, larger vessels, and affect the hand and feet, mostly the lower limbs, and many of these patients they present with gangrene. Myocardial infarction because of the atherosclerosis, hypertension and dyslipidemia is more common in diabetes patient. The point to remember that the patient who develop the myocardial infarction, who are diabetic, they don't present with symptoms. This is what we call as the silent infarct. These patients, because they don't have the pain during the attack, so the chances of mortality are more. Secondly, in the reproductive age group, female usually don't get myocardial infarction unless there is some predisposing factor for the lipid metabolism. But in diabetes, even the female, they can develop myocardial infarction during the reproductive age. Now, the gangrene, initially the patient have after some injury, small injury, may develop trophic ulcers, non-healing of the ulcers, and auto amputation of these fingers. And ultimately, when it progresses or the diabetes is not under control, the patient may have gangrene of the lower limbs, sometimes the renal atherosclerosis along with the microangiopathy causes the shrinking of the kidneys. The microangiopathy can involve in the kidney, any compartment of the kidney may be involved, but the most common is the glomerulus, then the interstitium and the tubules, blood vessels. In the glomeruli, there is a diffuse thickening of these glomeruli, these tuft, there is which is causes because of the collagen 4 is increased, there is more leakage of the proteins. So, most of the proteins are deposited on the blood vessels and causes thickening. There may be the involvement of the vessels, the arteriosclerosis, which is of the medium or the medium size vessels. There may be pyelonephritis. These patients are more prone to interstitial inflammation. And point to remember that the pyelonephritis in diabetes may develop necrotizing papillitis. There are very few conditions where one get the necrotizing papillitis, and one of them is the diabetes mellitus. There may be renal tubule involvement. The one is the thickening of the basement membrane, like the microangiopathy at all other places, or there may be more glycogen in the epithelial cells, what we call the Armamani syndrome. And because of all these features, the kidney becomes shrunken, they are smaller in size. So, this is one of the cause of small contracted kidney besides some other causes. Now, this shows the normal capillary glomerular tuft. This shows the thickening of the basement membrane, and these are the glomeruli where there is a thickening or there is a tuft, and there is an increase in the mesangial matrix. These are the sometimes one gets this nodular deposit. This is the eosinophilic material just like the amyloid, and it has to be differentiated from the amyloid. One can do the stain for the amyloid, but the only point which has to be remembered in diabetes is that these nodules, they push the capillaries toward the periphery, whereas in the amyloid they are entangled. So, these lesions are known as the nodal sclerosis or Kamal-Wilson disease, KW lesions. Now, the very interesting is that in diabetes mellitus, both afferent as well the efferent vessels at the hilum of the glomerulus are involved. They show thickening. This is as compared to the other conditions where only the afferent vessels are involved, but not the efferent. And all these conditions has to be differentiated from the old age changes, from the hypertensive changes, and from the amyloidosis. Now, why these patients are more prone to infections, especially the pyelonephritis? Because many of these function of these protective mechanisms, for example, the polymorphs, the macrophages, the migration, the release of the chemokine, they are defective in these patients, which ultimately leads to increased chances of infections. The ocular complications are many, but few are. The cataract is more common. Diabetic patient develop cataract in younger age as compared to normal population. They are more prone to glaucoma, diabetic retinopathies, optic atrophies. All these are complications of the diabetic microangiopathy. The other organ which is affected by the microangiopathy is the peripheral neuropathies. These patients have very characteristic gloves and stalks presentation of involvement of the nerves. For example, the hands and feet are involved, and these patients, they become the symptoms because of the involvement of the axons, small nerve fibers, and sometimes this peripheral neuropathy is painful. It may be that the vessels which supply these nerves, smaller vessels, which becomes thickened because of the microangiopathies, or there may be direct damage to the axons, which is further complicated by the trophic ulcers. Because the decreased sensation, these patients, they become ulcers, especially on the pressure points in the feet, which ultimately complicated by the gangrene and leads to amputations. Now, as I mentioned, these patients, they have very symmetric involvement of the nerves, what is called the gloves and stocking pattern of neuropathy, and the sensory is more as compared to the motor dysfunction. Sometimes there may be involvement the autonomic neuropathy, which manifests as sexual dysfunctions or disturbances of the bladder and bowel. Rarely these patients have diabetes mononeuropathy. Now, why these microangiopathic complications develop? Basically, there are three mechanisms. It may be non-enzymatic glycosylation, or it may be the activation of the protein C pathway, or it may be there are some organs where there is a passive influx of the glucose because of the raised levels, and this polyol pathway is affected and leads to the microangiopathy. In the non-enzymatic glycosylation, it is actually the process by which the glucose chemically attaches to the free amino acids of protein without the help or the involvement of any enzymes. And these products, what we call the formation of advanced glycosylation end products, which have receptors on certain tissues and goes and attach there and activate those and causes complications. The ACE receptors, they are on many cells, but monocyte, macrophages, T cells, endothelial cells, smooth muscle cells, meningeal cells and neurons are the one which are rich in these ACE receptors. So, these ACE products, they goes and attach there, causes activation of these tissues and ultimately leads to the complication. Now, this may affect the matrix, it may affect the intracellular compartment, it may affect the plasma proteins, and all those mechanisms which leads to atherosclerosis or the vascular complication or the decreased, for example, the fibrinolytic pathway which causes the lysis of the fibrinogen which is affected. So, all these mechanisms actually leads to the coagulation and decreased destruction of these thrombus and leads to the microangiopathic complications or the macroangiopathic complications. Now, because of the disturbance of the polyol pathway, as I mentioned, this some tissue don't require insulin for the glucose transport, and because of the raised glucose levels, that is this glucose goes to this tissue inside and there is an involvement, it is broken into the fructose and there is an involvement of the sorbitol which is intermediate product, and it is more toxic to some of the tissues. On the other hand, there is utilization of the NADH, NADPH, and this is also required for the glutathione pathway and ultimately leads to the activation of the oxidative stress and the oxidative pathway and free radical injuries. All these factors contribute for the complications. Now, this shows the pathogenesis of the diabetes mellitus. There is a decrease in the insulin, there may be decrease in the glucose utilization. It all leads to hyperglycemia, and this hyperglycemia affected many organs. There is underutilization of glucose in the fat, in the muscle, in the liver, and this glucose threshold for the kidney, when it is raised, the glucose goes to in the urine, it causes glycosuria, and because of the osmosis it causes the polyuria, and there is body needs more water, so there is polydipsia, and because insulin is less, so there is catabolism. All these leads to the polyphagia. So, this explains the three symptoms which are common in diabetes: polyuria, polydipsia and polyphagia. Ketosis, ketonuria and coma are more common in the type 1 diabetes, whereas in the type 2 diabetes it is the hyperosmotic diuresis which sometimes leads to the coma. This shows in nutshell the mechanism of type 1 and type 2 diabetes, and in the end this picture shows the complication of diabetes, which are very important and the most important, one of the cause of mortality and morbidity in diabetic patients. Thank you.